1. A 32-year-old woman with a history of multiple pregnancies receives a transfusion after surgery. 10 days later, she presents with mild jaundice and malaise. Labs reveal a drop in hemoglobin and elevated indirect bilirubin. Direct Coombs test is positive. What is the most likely diagnosis? A. Acute hemolytic transfusion reaction. B. Anaphylactic transfusion reaction. C. Delayed hemolytic transfusion reaction. D. Febrile non-hemolytic transfusion reaction. E. Graft versus host disease. Delayed hemolytic transfusion reaction. Explanation: delayed hemolytic transfusion reaction occurs 1 to 2 weeks post-transfusion due to anamnestic IgG response against minor RBC antigens, e.g. HCl. It leads to extravascular hemolysis, typically mild and self-limited. A. Acute hemolysis occurs within minutes to hours. B. Anaphylaxis happens immediately with respiratory distress, hypotension. DHTR presents with fever chills within hours. EGVHD occurs days to weeks later with skin, liver, and GI symptoms. Question 2. Which of the following best explains the pathophysiology of a delayed hemolytic transfusion reaction? A. IgE-mediated mast cell degranulation. B. Preformed IgM antibodies causing complement activation. C. Activation of neutrophils by cytokines in stored blood. D. Memory B-cell-mediated IgG response against minor RBC antigens. E. Direct donor lymphocyte attack on host tissues. Answer D. Memory B-cell-mediated IgG response against minor RBC antigens. Explanation: DHTR is a type 2 hypersensitivity reaction where prior exposure, e.g. pregnancy or transfusion, leads to memory B cells that produce IgG antibodies after re-exposure targeting Rh or minor antigens, leading to extravascular hemolysis. A. IgE anaphylaxis. B. IgM equals acute hemolytic reactions. C. FNHTR. E. GVHD. Question 3. Which of the following laboratory findings is most consistent with delayed hemolytic transfusion reaction? A. Positive direct antiglobulin Coombs test and hemoglobinuria. B. Thrombocytopenia and elevated creatinine. C. Leukopenia and decreased haptoglobin. D. Elevated indirect bilirubin and spherocytes on peripheral smear. E. Elevated troponin and decreased BNP. Answer D. Elevated indirect bilirubin and spherocytes on peripheral splenation. Extravascular hemolysis, as in DHTR, shows elevated indirect bilirubin, positive Coombs test, and spherocytes due to partial phagocytosis of antibody-coated RBCs. Hemoglobinuria is more typical of intravascular hemolysis. B. Suggests HUS or D, not DHTR. C. Leukopenia isn't a hallmark of DHTR. E. Suggests myocardial damage, not hemolysis. Question 4. A patient receives a blood transfusion and 10 days later is found to have a mild drop in hemoglobin and elevated bilirubin, but is otherwise asymptomatic. What is the most appropriate management? A. Administer epinephrine and corticosteroids. B. Initiate broad-spectrum antibiotics. C. Stop all transfusions permanently. D. Provide supportive care and monitor labs. E. Begin iron chelation therapy. Answer D. Provide supportive care and monitor labs. Explanation: DH typically self-limited and requires no aggressive treatment. Monitoring and supportive care are sufficient unless symptoms worsen. A. Used for anaphylaxis, not DHTR. B. No infection is suspected. C. Future transfusions are still possible with better cross-matching. E. Iron chelation is for chronic transfusional iron overload, not a single episode. Would you